morning. Why don't we go ahead and get started? It's my pleasure to introduce our speaker today. Dr. Wolf did her training at the University of Michigan and went to medical school at Medical College of Ohio. She then went on and did her training at Legacy, where she stayed on as chief resident and did her endocrinology training up at OHSU. She is now the Associate Medical Director for the Providence Brain and Spine Institute and joined Providence back in December and is at Providence Endocrinology Westside now. She did this talk on hypogonadism a couple of years ago over at St. V's, and I know for myself and Dr. Hopkins, we get so many questions about testosterone replacement, and there's a lot of controversy out there about it, so I was really excited to have her come and educate us today on what's new and what we've learned about testosterone replacement. So thank you, Fawn.
Thanks, Liz. All right, so I have this microphone here. Is this volume okay? Can you hear me okay? So as Dr. Stevens said, I gave this talk back in 2010, and I have to say there's been a lot of data since then on this subject. Some, of course, has helped to clarify some of the issues. Some, as usual, has helped to just confuse us more. So what we'll do today is we'll go through some of the recent studies and see how that might apply to our clinical practice. So we're going to start with a couple of nice, fun, clear-cut cases. We'll look at a few not-so-clear-cut cases. We'll talk about how testosterone changes with age and how it relates to health outcomes. We'll review the benefits of testosterone therapy, the potential risks, and then we'll finish with a few slides on just sort of nuts and bolts of general management of hypogonadism. So the first, a clear-cut case, 36-year-old white man. He meets with a new primary care physician after not having had insurance for about 10 years. He worked in construction, didn't have any options for insurance that he could afford. He complained of fatigue, decrease in libido and stamina. He'd noticed he had stopped growing a beard. He had lost some axillary hair. And this had all started about 10 years prior. On his past medical history, he was healthy. He had gone through a normal puberty. He had fathered 2 children. On his exam, he appeared younger than his stated age. It was noted that he had a loss of secondary sex hair, low muscle mass. He was pale. And slightly small testes. So they were not prepubertal, but on the small end for adult testes. His total testosterone is 10, and yes, that is the normal range that you're used to thinking of, where the normal lower limit of normal would be about 250 or 300. So his was very low. FSH was low, prolactin normal. He also had suggestion of mild central hypothyroidism as well as growth hormone deficiency and anemia, likely from the hypogonadism. And his bone density showed osteopenia. So his MRI revealed an almost 6-centimeter partially cystic cellular mass. He underwent surgical resection, and the path was consistent with a craniopharyngioma. Postoperatively, he had persistent hypogonadism. He had ongoing hypothyroidism, growth hormone deficiency, as well as new-onset adrenal insufficiency. So he is pan-hypopit. He started on replacement hormones, and in 6 months, he says, "Doc, I feel like a new man." So here is my patient at 36. I know this picture looks like it was taken from the 70s, but I promise it was just a few years ago. It was just it was a group photo, so I had to zoom in. So severe hypogonadism due to a large craniopharyngioma, and then here he is just a couple of years on replacement hormone therapy. And you can tell he is a new man. He's filled out, he's able to grow a beard now, as you can see. And now he looks like a man in his late 30s as opposed to, perhaps somebody in their teens or 20s. Second clear-cut case, 32-year-old Hispanic man referred by his primary for severe hypogonadism. He notes lack of libido, lack of stamina and muscle mass, unable to grow a beard. His past medical history doesn't have any diagnoses, but he notes that he feels like he never really completely went through puberty. Voice didn't completely change, never developed secondary sex hair, and his wife has been able to conceive, and his workup showed oligospermia. On his exam, he appeared much younger than stated age, no secondary sex hair, prepubescent testes, and this was one of those delicate situations where I walked in the room and there was a person who appeared that they were maybe 16, although I had his date of birth in front of me, so I know he was in his 30s, but he appeared like he was 16, and then there was a woman who appeared that she was maybe in her 40s. And so I didn't ask the question, how are you two related, when I first walked in, and then it got to the point that it was too late to ask it. So I was trying to delicately navigate the situation, and I did realize that no, they are husband and wife, because they started to talk about her issues with conceiving and his low sperm count. So his total testosterone was 40. FSH is elevated at 54, karyotype XXY, so he has Klinefelters. 6 months of testosterone therapy for him, and he says, "Doc, I feel like a new man." So here he is prior to therapy. Again, very young looking, very minimal facial hair. And here he is just a couple of years afterwards. So you can see now he is masculinized. He has the beard growth. He's certainly filled out. One of the things I think that's striking when you see these pictures side by side, if I look just at this picture, I wouldn't necessarily say that he has temporal balding. But if you compare it to this picture, this is not a normal hairline for a man in his 30s, generally speaking. And so you can see the difference with just 2 years of testosterone. He now also has a neck tattoo, which I do not take any responsibility for. But he does now appear as though like a man in his 30s. So these cases, sure.
Reporting the FSH but not the LH. Can you explain that?
I think we had both, and they were both moderately elevated. So I just listed the FSH. Yeah, I don't recall the LH off the top of my head. So these are both, they're interesting cases. They're rewarding to treat. With these obvious pathological diagnoses, there's a very clear-cut benefit-risk ratio. But I suspect most of the cases that you're seeing, and even most of the cases that I'm seeing, fall into more of a gray zone in terms of presentation and also benefit and risk analysis. So we talk about androgen deficiency. A lot of terms are thrown around: late onset hypogonadism, low T syndrome, andropause, my favorite, menopause. And so I thought it would be helpful today to talk about some of the newer data regarding these subjects. So how about these two patients? We've got a 52-year-old man with a BMI of 32, type 2 diabetes with an A1C of 7.3. He has low libido and requests testing for low T. He's found to have a testosterone of 220. And then we have a 68-year-old man who is very healthy, exercises regularly. He's noticed some decline in libido and stamina over the past few years, and he also requests testing for low T. And his total testosterone is 190. So again, not so clear. So we will be coming back to these cases. I have just a brief review of the anatomy and physiology. So we've got the hypothalamus secretes gonadotropin-releasing hormone. Pituitary secretes FSH and LH, which then stimulate production of sperm and testosterone from the testes. Testosterone has a number of effects on the body, in part because it really acts as three hormones. So the testosterone hormone directly stimulates androgen receptors and helps contribute to muscle mass. Testosterone is also converted via 5-H alpha reductase to DHT, and then testosterone can also, and DHT plays a role in sex hair and prostate. And then testosterone is aromatized to estradiol, which plays a large role in bone density as well as muscle mass and sex drive. So the first question, I have a few questions scattered throughout here, very informal. I don't have the clicker for you guys to click. If you want, somebody just wants to shout out the answer. So which of the following is most likely to increase in response to testosterone therapy? So we've got erectile function, libido, attractiveness to others, or Drakkar Noir clone. And I'm probably dating myself with the residents a little bit. This was a clone that was very popular in the 90s. All the cool guys wore it. So any shout outs for erectile function, libido? Yeah, so libido. Low testosterone primarily causes low libido. Of course, it goes hand in hand with erectile function. And then libido is what improves the most with testosterone therapy. So we know that testosterone declines with age. We have a number of longitudinal studies, Framingham, Baltimore, as well as cross-sectional data, which shows this. Both the total and the free testosterone decline. However, as we age, sex hormone binding hormone increases, and so the free testosterone drops relatively more so than the total. So the free testosterone drops by about 1 to 2% per year. So this was a great paper that came out last year in the Journal of Clinical Endocrinology and Metabolism. One of the criticisms of testosterone studies is that a lot of studies use different lab assays, and so we get different looking results back, and sometimes it's hard to compare apples to apples. And so what these authors did is they took 4 large cohort trials, which added up to just over 9,000 subjects in the US and Europe. So the Framingham European Male Aging Study, which is EMAS, osteoporosis fractures in men, that's the Mr. Oss study, and then the male sibling study of osteoporosis, CBLOS. And what they did is they took 100 samples from each cohort. They had frozen fasting serum samples, and they then processed them in the CDC clinical reference lab, and they obtained results then, and they were able to come up with these normalizing equations that basically harmonized the results from study to study so that you really could compare apples to apples. What they found that the testosterone levels in each of the 4 individual studies initially had some variability study to study, and then once they processed those samples in the CDC reference lab, the variability went down quite significantly. So I think it's also nice to see this data because we can see on this first slide here I have for the men less than 40 years of age, and the next slide we'll look at the older decades, but we can see the different percentiles and where people fell out. I think it's helpful to see these numbers. We get used to seeing the numbers that we see all the time. So it's pretty common for me to check a testosterone level and to see a level in the 200s or 300s. And if I get a reading back in the 400s, I think those guys Superman. But it's actually helpful to see, where these numbers fall out. So bottom 2.5th percentile, again, this is men less than 40, is going to be somewhere in the low 200s. Middle 50th percentile, right around 500. And then top 2 to 5 percentile in the 800s to low 900s. This is for total testosterone. And the reason I just have these 2 studies up here, the other 2 cohort studies didn't look at men in this age range, so this is just the Framingham and CBLOS. So here's the data then for the men with each decade of life. Again, so that I wasn't throwing 100 numbers up on the page, I'm just showing the European male aging study data. The data from the other trials was pretty similar, but we can see here lowest 2.5th percentiles down around 200. It really drops off above the age of 70, although they have fewer participants there. The 50th percentile, again, in the 400s, 97th percentile in the 900s. And you can see here that, yes, the numbers do decline with age, but really maybe not as significantly as you would think. So the next question is whether or not endogenous testosterone levels correlate with health outcomes, and it appears that they do. That's been shown in a number of studies, and this is just one of them. So the EPIC Norfolk Prospective Population Study, this is a nested case control study based on 11,000 subjects aged 40 to 80. They were surveyed in the mid-90s and then again in the early 2000s. They specifically or purposefully excluded patients with baseline cardiovascular disease and cancer because we know that acute illness can induce a drop in testosterone, and so they didn't want to muddy the water, so to speak. And what they found was that endogenous testosterone was inversely related to mortality, so all-cause as well as cardiovascular and cancer mortality. And the men in the highest quartile of testosterone had a 25 to 30% lower risk of mortality compared to the lowest quartile. And this relationship persisted even after an adjustment for a number of cardiovascular risk factors. So low testosterone does appear to be predictive of low health outcomes, at least there's an association. Most cross-sectional studies report lower endogenous testosterone levels are associated with less favorable cardiovascular disease risk profiles, as we can see here. A number of observational studies from the last 10 to 15 years have suggested an association between low testosterone and the presence of coronary events, but it's still not clear if this is a causal relationship or if it's just that testosterone is a biomarker of general poor health. Low testosterone is also associated with increasing symptoms. We see that from a number of population studies, so more sexual dysfunction, decrease in muscle mass and strength, decrease in bone density, more fractures, anemia, some down mood. And so the question we keep coming back to is there a syndrome of age-related hypogonadism? And so we know that these complaints increase as men age, testosterone declines as men age, and so is there a true pathological cause, or is it just true and unrelated? And some of this may have to do with to what degree do we want to medicalize aging versus what is just normal aging. But this next study, I think, helps frame this to a degree. At least I found it a bit interesting and helpful. So this came out in 2012, Journal of Clinical Endocrinology and Metabolism. These authors took the cross-sectional data from the European male aging study, and this was almost 3,000 subjects, community-dwelling men in their 40s to 70s. And their aim was to find objective evidence of androgen deficiency based on both biochemical as well as symptoms and end organ outcomes. And so these authors defined late onset hypogonadism as low testosterone for no reason other than aging. So appropriately, men with known pituitary testicular disease or on meds that could affect testosterone were excluded. And they broke them up into a more severely low level and then a moderately low level and then a more severe low level. In order to be defined as having this late onset hypogonadism, they also had to have sexual complaints. So men who had a low testosterone reading on their lab but felt perfectly fine wouldn't fall into this category. They really wanted to try to find perhaps a syndrome of low late onset hypogonadism. And so when using this definition, just over 2% of the men in this cross-sectional data of community-dwelling men had this late onset hypogonadism. And what they found were graded and significant associations in 3 target tissues that are known to be androgen responsive, so hemoglobin, bone density, and lean muscle. And so we have here hemoglobin was clearly lower in the more hypogonadal patients. Bone density was lower. This is the mean upper arm circumference was lower. Waist circumference trend towards bigger. HOMA-IR, that's a tool to measure insulin resistance. More insulin resistance only once you got to below 230 for total testosterone, and then physical performance was worse as well. And these relationships again held after adjustments for age and BMI and comorbidities. So perhaps you could say, in approximately 2% of patients who have low testosterone for no reason other than aging, they do appear to have some objective differences compared to men with higher testosterone levels. Now we have to contrast this against the striking prescribing data. And so the number of studies have looked at this, just the vast increase in testosterone prescriptions that have occurred in the United States over the past 10 to 15 years. Here's one study, it went from 0.8 to 2.9% of all patients receiving a testosterone prescription. Another study found a 10-fold increase in testosterone sales in this decade in the US. Interestingly, it was 40-fold in Canada. But it's not just a bunch of Canadians taking testosterone, it's Americans or people from the United States getting prescriptions and then sending them up to Canada. This was a study that was also concerning. 2014 reviewed private and Medicare insurance claims that showed inadequate lab testing prior to testosterone initiation. So half of patients in this study had no testosterone lab test that they could see. They only went back, I think it was either 3 or 6 months before. So it's quite possible somebody had had a testosterone level a year before, but really that should be repeated before starting therapy. 40% had just one test and only 10% had the multiple evaluations, which is what is the recommendation. And a lot of this, of course, is concerning for the loosening of the term male hypogonadism, and a lot of it likely is a result of direct to consumer marketing. Question 2, what might indicate illicit testosterone use? So somebody that is taking testosterone and not telling you. So low testosterone, low hematocrit, elevated FSH, low T, low HCT, suppressed FSH, low T, high HCT, suppressed FSH, or low cut white tank top, Eye of the Tiger ringtone. I think I definitely get these guys that come in, they look like they just came from the gym, they're huge, and somehow their testosterone is low. So any thoughts here?
High hematocrit.
Yeah, so the high hematocrit is the tip-off. I don't know how often this happens, but I think it's probably not that difficult. Guys take testosterone illicitly. They take it for a number of months or a year or so. They stop taking it. They're going to have induced secondary hypogonadism, and so their testosterone is going to be low when they come off of it. But their hematocrit is still going to be high from the general exposure. Their FSH is still going to be low. So high hematocrit's a tip-off. Also, if the FSH is completely suppressed, we typically don't see that with hypogonadism other than in patients who have a very large pituitary tumor or who have gone through apoplexy, but that would be potentially another tip-off if their FSH is severely low. So we'll look through some of the benefits of testosterone in men. This slide, again, is looking at those first 2 cases. So hypogonadal due to a known cause, somebody who's got an obvious big pituitary tumor or some other issue like this. So again, it's going to lead to normal virilization, marked improvement in libido, improvements in muscle strength and mass. These are some studies from the 90s where they took severely hypogonadal men and started them on testosterone replacement, and they saw pretty impressive or pretty good increases in fat-free mass, bench strength, squat strength, And then here's the study looking at bone density, pretty drastic improvement in bone density, and then they were maintained in the normal range after 2 years of therapy. Mood and cognitive data is fairly mixed. What about the benefits of therapy for late onset hypogonadism, though, if we're going to use that term? So in 2010, the Endocrine Society guidelines stated that in the absence of known pituitary or testicular disease, testosterone therapy is suggested only for men with unequivocally, low serum testosterone levels on more than one occasion, accompanied by symptoms of testosterone deficiency. However, even this panel of experts was split into calling either 200 versus 300 as the threshold for low. Prior randomized controlled trials have shown, and late onset hypogonadism have shown modest improvement in bone density, with the men with the lowest bone density at baseline showing the greatest improvement. However, we have no fracture data. Modest improvements in body composition. I think a lot of guys think if they start testosterone, they're going to lose 30 pounds and gain muscle. It's really on average about 2 to 3 kilograms in either direction. It's in a positive direction, but the overall effect on weight is neutral. Modest improvements in A1C, 0.1 to 0.3, and insulin resistance. Consistent improvement in libido, so that's one thing that is more consistently seen. Modest improvements in mood. I put these two studies up here on the same slide. They both came out in 2010. They were both randomized controlled trials, and they both looked at older, frail men with multiple comorbidities to see if testosterone replacement could improve physical functioning, strength, avoid falls, that type of thing. And they chose men who were, really just in the lower end of normal, so less than 350. A lot of these, you would be hard to say that they had overtly low levels. They were just in the lower part of normal. Both trials did show improvement in leg strength. One trial showed some improvement in sexual and physical function, the other with bench press and stair climbing. So modest improvements. There's a trend, I believe, towards fewer falls, but not statistically significant. The New England Journal, this is the TOM trial, we'll talk about later, it did have some cardiovascular warnings surrounding it, and that's something that's talked about a lot. So we'll look at that a little later when we're talking about risks. So in 2003, the Institute of Medicine concluded that there was insufficient evidence at that time for any well-established benefit and recommended a series of randomized controlled trials for further evaluation. And so the testosterone trials were born, and these were published in the last year and a half to 2 years. So the testosterone trials, effective testosterone treatment in older men. This was a large trial. It was not large so much in terms of subjects, but they had a lot of different arms. So 790 men aged 65 and older, average total testosterone of less than 275 on 2 occasions. And so 14% of the initial men qualified, accompanied by one or more symptoms that would qualify them for at least one of the arms of the studies, and we'll go through that. They appropriately, again, excluded known pituitary or testicular disease, excluded men with a testosterone less than 100. They didn't want to include those with pathological hypogonadism, again, thinking of my first 2 cases. Excluded men with prostate cancer or high risk, high hematocrit, very recent MI, uncontrolled blood pressure. They used androgen 1% to maintain total testosterone in the 500 to 800 range for 1 year. So all of the men had to qualify and take part in at least one or more of the main trials. So we have the physical function trial, sexual function or vitality trial, and then they had optional participation in the cognitive, bone, anemia, or cardiovascular arms. So there was a high rate of coexisting conditions. 62% were obese, hypertension, 14% had a prior MI. 705 completed this study, the 12-month study, so there's fairly good retention, and 91% of the participants maintained a goal testosterone in the 500 to 800 range. So this is one of the ways that this trial is set apart from a lot of the previous trials. They actually had well-defined levels before receiving therapy, good retention rate, and a good amount of patients that achieved the goal testosterone. And that's not been the case for a lot of the other studies, where in a lot of the other studies, those numbers just aren't even given, at least in terms of where the T levels ended up. So we'll go through the sexual function trial first. So at baseline, men in this trial had some sexual function complaints, low scores on questionnaires. The testosterone group saw significant increases in sexual activity, desire, and erectile function. The response was somewhat less at 12 months. The men in the testosterone groups were more likely to report or perceive improved sexual function as well. And again, just to go back here, this is really not any different than results we've seen in the past, but again, just nice to know, nice to see the data in terms of the retention and that they actually got the testosterone levels they were aiming for. Physical function trial, so this included to participate here, it required a self-reported difficulty of walking or climbing steps and a slower recorded gait speed on the 6-minute walking test. When they just looked at the men who qualified for this arm of the study, there was a trend toward improvement, but it did not reach statistical significance. However, they recorded these measures in all 790 men. So when they looked at all 790 men, then it did reach statistical significance. And the difference, the improvement wasn't any different versus those who qualified versus those that didn't. I think just the power was greater once they had all men in the study. Improvement in walking times and change in physical function questionnaires. And again, the men in the testosterone-treated group were more likely to report or perceive improvements in walking distances. The vitality arm, I had a little trouble at first figuring out what they were getting at with this, but they're getting at physical, overall energy, vitality, mood. So basically, their oomph, their spark, and now I think of Austin Powers when I think of this arm. So their Austin Powers score, essentially. So they, in order to qualify here, they had to have complained of fatigue, low vitality, and low scores. Again, like the previous trial, they saw a trend towards improvement in these scores, but it only reached statistical significance when all the men were included. There were significant but small improvements seen in secondary outcomes, these symptom scores, the positive and negative symptom score. And again, like the other two, men in the testosterone treatment group were more likely to perceive or report that their energy was better. So it seems that one thing that testosterone does is increase confidence. And all these arms, the men perceived that they were doing better, and in fact, they were doing slightly better. So the cognitive and the anemia arms, the cognitive, they looked at a subset of patients, so about subjects, close to 500, with age-associated memory impairment. So they had subjective memory complaints as well as objective memory impairment, but they excluded subjects with overt dementia and depression. They saw no improvement in overall cognitive functioning other than an isolated trend towards improved executive functioning, but otherwise pretty neutral results. In the anemia arm, as expected, testosterone increased hemoglobin in men, both who had explained anemia, but also in men whose anemia was thought to be due to something else. So if somebody had confirmed iron deficiency anemia, their hematocrit also improved. And it improved in about half of subjects. They saw greater than a 1 nanogram per deciliter increase in hemoglobin. And about half of the subjects were no longer anemic at the end of the 12 months. So the bone arm, not the arm bone, but the bone arm. So we know as men age, they have a decrease in bone density and more fractures. In men who are frankly hypogonadal due to known disease, bone density declines and fracture increases. And testosterone, as we saw before, increases the bone density fairly dramatically. Prior studies on testosterone therapy in older men, however, have been inconclusive. One randomized controlled trial showed improvements in bone density, but only in those with the lowest serum testosterone levels. So the bone arm of this trial, the primary outcome was a change in baseline of volumetric bone density of trabecular bone as measured by quantitative CT. Volumetric bone density was chosen for a few reasons. One, it's not influenced by degenerative joint disease as the aerial bone density is at the spine. And it can differentiate trabecular from cortical bone. So testosterone, as it's aromatized to estradiol, the estradiol affects the trabecular bone more so than the cortical bone. So the secondary outcomes were volumetric bone density, bone strength estimates, and aerial bone density by DEXA. They excluded men who were on any medication known to affect bone or severe osteoporosis. And you'll note here that these men actually were not osteoporotic. They weren't even osteopenic at the start of the study. They had normal bone densities. So here's the effect of the testosterone on the volumetric bone density. And so we can see pretty significant improvements here in the testosterone arms at the spine and at the hip. And these increases are actually fairly comparable to what we see with the anti-resorptive therapy. Here is the effect of testosterone on estimated bone strength. And bone strength estimates are something that's talked a lot about in the osteoporosis literature. It comes from quantitative CT data. And they do correlate well with the physical strength of human vertebrae as well as fracture risk. So again, improvements in the spine and the hip. And so I think when you're thinking about testosterone and bone, if you have a man who's osteoporotic and also hypogonadal, you're going to want to also use an anti-resorptive agent. I think especially for an older subject, for a younger patient, potentially the testosterone could be the main therapy. But at this point, since we don't have fracture data, you would want to think of this as mainly just a potential add-on benefit, that their bone density likely will improve. So now we'll move forward talking about the potential risks of using testosterone for late onset hypogonadism. We've got cardiovascular data, prostate, erythrocytosis. So there were a handful of meta-analyses in the early 2000s showing a neutral effect of testosterone use on cardiovascular disease. Since then, there's been a number of trials, so we'll go through those. First, we'll look at some of the retrospective data because most of it is retrospective data. So a handful of trials have suggested cardiovascular risk using testosterone therapy. This top one from 2013, JAMA. This is a very large retrospective cohort analysis of men with low testosterone who underwent coronary angiogram at the VA. And the primary outcome was all-cause mortality. The hazard ratio was 1.29 in those that used testosterone replacement, but the raw data actually showed outcomes that favored testosterone. And so there was a lot of criticism over this trial to the point that some investigators have called for retraction of the paper. Again, the raw data actually showed better outcomes in those who used testosterone, and it was only after they completed multiple statistical manipulations that the opposite conclusion was reached. This next trial here, 2015 JAMA Internal Medicine, again, a very large, greater than 55,000 cohort study, evaluating the risk of non-fatal MI in the first 90 days after initial testosterone prescription. And the ratio did suggest a greater rate of MI with the testosterone prescription, although the absolute risk was fairly low. Both of these trials were criticized for a lack of data on the testosterone levels either before or after treatment, as well as the potential etiologies of the low testosterone. And then there have been a handful of retrospective trials suggesting potential benefit. So there's actually quite a few more, but I'm just showing these two. The top one, 2012 Journal of Clinical Endocrinology, men with a baseline serum total testosterone of less than 250, testosterone replacement therapy was associated with a 39% reduction in all-cause mortality. This one here was nice to see as well. This is interesting. The 2015 European Heart Journal studied the relationship between normalization of the testosterone levels following testosterone replacement therapy and all-cause mortality, as well as cardiovascular events. And so the patients who received the testosterone therapy and normalized their serum testosterone had a lower risk of all-cause mortality, MI, and stroke compared to those who received testosterone but whose levels did not normalize. And the ongoing concern, however, so these two studies look pretty good. The ongoing concern, however, though, is that it might just be the healthier men that are receiving the testosterone prescriptions. And of course, they try to account for that with accounting for age and BMI and statin use and past MI history and that sort of thing. But even so, there might be just something when you're looking at the patient face-to-face in the office, you might be giving the healthier patients testosterone. And then in 2017, this was a retrospective cohort study of over 44,000 men. This was a Kaiser study, 40 years and older. The inclusion period there for 10 years. And they classified them basically into ever users and never users of testosterone. The primary outcome was a composite of cardiovascular endpoints, and the adjusted hazard ratio in the ever users was 0.67. So again, a handful of observational retrospective data that suggests benefit, but again, hard to know if you're not just giving the testosterone to the healthier people. So now moving on to the randomized controlled trials, and we don't have as many of those. So this was that TOM trial again from 2010. This is the one that took men older than 65 who were intentionally medically frail, poor mobility, low or low normal testosterone. They randomized them to placebo or topical testosterone. And the trial was stopped early. So 23 men in the testosterone group versus 5 in the placebo group had cardiovascular-related adverse events. So this paper got a lot of press. A couple of criticisms that have been talked about with this paper is these testosterone doses are pretty high. So I would typically start a man off on probably 50 milligrams a day. Excuse me, I might go up to 100 milligrams a day. I don't think I would ever go to 150. And especially they went up to 150 even if their testosterone stayed less than 500. So they were pretty aggressive with the replacement. So potentially it was a dose issue. The other criticism being that a lot of these cardiovascular-related events were somewhat soft endpoints. So one was syncope, one was tachycardia with lightheadedness. So it may or may not have been related to the testosterone, and certainly some of the events, though, probably were related to the high doses they used. Just for comparison, this was that other 2010 randomized controlled trial that looked at basically the same cohort of men. So men above the age of 65, intentionally medically frail, had just low normal testosterones of less than 350. Here randomized to placebo or just 50 milligrams a day. This one showed no increase in major adverse cardiovascular events. Neither of these studies was powered to look at cardiovascular events, but I show them both just because the TOM trial got a lot of press since it was stopped early for the cardiovascular events. This is the adverse events from the T trials that we talked about. So we'll talk about the prostate here in a little bit, but it was no significant difference in the cardiovascular events. So 2 MIs in the testosterone group, just 1 in the placebo group, 1 death in the placebo group from cardiovascular cause, none in testosterone, same number of MIs and strokes. Overall death rates, 7 in placebo, 3 in testosterone. So we have limited prospective randomized trials, and they have not been powered to look at cardiovascular events. We also have a few prospective randomized controlled trials that look at, that attempt to assess atherosclerosis. So we'll look at a couple of those now. So this was the 2015 TEAM trial. This was just over 300 men with either low or low normal testosterone, randomized to testosterone gel. They aimed to keep the testosterone between 500 and 900. Went on for 3 years. The primary outcome was carotid artery intermedia thickness and coronary artery calcium scores. And you can see there was no difference in the placebo versus the testosterone arms. And then this is the cardiovascular arm of the T trials. So moving on to that arm of the of the T trials, this also attempted to look at atherosclerosis. So again, in prospective randomized controlled trials, only 138 of those 790 participants were in this arm. At baseline, these subjects had high cardiovascular disease risk, high coronary artery calcium scores. The primary outcome was non-calcified coronary artery plaque volume, which was significantly greater in the testosterone group. And the secondary outcome was total coronary artery plaque volume, which was also significantly greater. I might have duplicated that there. The coronary artery calcium scores were no different. So the non-calcified plaque volume is a relatively new technique that admittedly I really don't know much about. From what I understand from reading this paper and a few other papers on it, it has fairly good reproducibility, has been associated with MIs and cardiovascular events in limited data so far, but we don't yet have any long-term data in terms of how it relates to cardiovascular prognosis or its relationship with plaque remodeling or rupture. I spoke with a couple of cardiologists and they agreed it's a new tool, probably has yet to prove itself. So just to summarize all of the cardiovascular data, we have retrospective and observational data that generally shows mixed outcomes. Although I showed 2 in each group, they generally favor testosterone therapy. Again, though, despite multivariate analysis adjustments, it might just be that the healthier patients are the ones given the testosterone prescriptions. Prospective trials are very limited, so they've been underpowered to detect cardiovascular outcomes. And most studies that look at cardiovascular outcomes do not show any difference other than the TOM trial from 2010, which was the one that used the very high testosterone doses. So far, we do have a handful of randomized prospective trials looking at carotid artery intima media thickness and coronary artery calcium scores, and we don't see any difference there. And then this plaque volume data is relatively new, but did show a detriment from the testosterone. moving on to the prostate. What about the prostate? Sounds like a bad network series. What about Kevin's prostate? We've got prostate volumes. What we've been taught and told over the years is that prostate volumes and serum PSA may increase in response to testosterone therapy. And typically, though, the expectation is that they're just going to reach those of age-matched eugonadal men. So maybe they'd be lower if you're hypogonadal. You get started on testosterone, they just go back to what you would normally be given your genetic potential. The thought is that since prostate cancer is partly testosterone dependent, in theory, the risk of prostate cancer would be lower in hypogonadal men, and the risk would rise with rising testosterone levels, but data to support this really is lacking. So this is one trial here. This was a 2006 trial in JAMA. They took 44 men in their 40s to 70s with symptomatic hypogonadism, total testosterone less than 300. All of them underwent prostate biopsy before and then after 6 months of therapy. Their serum testosterone levels rose to mid-normal range, although interestingly, the prostate tissue levels of testosterone and DHT did not change. And here's a busy slide with a lot of numbers, but essentially they saw no changes in prostate histology or volume, tissue biomarkers, gene expression, cancer incidence or severity, or their IPSS, the prostate symptom scores. The treatment group, the PSA, rose slightly but remained in the normal range. And so this is nice to see for sure, but we have to remember it was only 6 months of therapy. And the estimates are that it would take a trial of probably 6,000 men randomized to testosterone therapy for 5 years before we could definitively see an increase or not of prostate cancer. There have been a handful of meta-analyses which have also been reassuring. This 2010 meta-analysis found no effects of testosterone therapy on the incidence of prostate cancer, need for biopsy, PSA, or symptom scores. 2016 meta-analysis also showed no relationship between prostate cancer and endogenous testosterone levels. And then furthermore, testosterone replacement for symptomatic hypogonadism did not appear to increase either PSA or risk of prostate cancer. There's been even more recently a paper that was just published in the last few months. It was a retrospective review that actually found similar rates of prostate cancer in men who took testosterone versus those that didn't. The men that took testosterone, however, had less aggressive forms of prostate cancer. So again, you might be looking at the patient and not giving them not giving them testosterone if you think they're at higher risk. So you don't know for sure if that shows that testosterone is a benefit, but at least it is reassuring that it does not appear to increase risk of aggressive cancer. So the recommendations, these come from the 2010 Endocrine Society guidelines that have not been updated since 2010. Digital rectal exam and PSA prior to starting therapy. If BPH is present, the symptom score can be calculated and then consider treatment of the BPH prior to testosterone therapy. I sometimes share these patients with urologists, and they are pretty comfortable with, even if with a man with moderate BPH, to treat the BPH at the same time they're treating the hypogonadism. We have these guidelines for when to referral to urology that's based on both a development of a palpable nodule, of course, that would make sense. We have these PSA guidelines that are all over the endocrine literature, and I fully realize don't have much to back them up. I spoke with a urologist about this, and they agreed with these guidelines. They said, well, we really don't have much else. So they thought for men who are on testosterone, it's reasonable to follow these guidelines. I tried to find the original data where this came from, and I couldn't. There was one paper that was referenced for this that went back to the 80s or 90s, and it didn't mention this at all. So I'm not sure where these numbers actually come from. But certainly if symptom scores rise, or if you develop a new palpable nodule, that would be reason to probably hold the testosterone and refer to urology. So now taking a step back, in general, thinking about who do we screen? So there's no evidence to support population-based screening whatsoever. So we do it based on case detection. So certainly if they have signs or symptoms of low testosterone, anybody who's on chronic glucocorticoid or narcotic use with symptoms, again, I'm not going to go ahead and screen everybody on these meds, but if they have the development of symptoms that are concerning, then I might do so. Unexplained anemia, I think certainly makes sense. Fragility fractures, especially in younger guys. A known pituitary disorder, so generally a pituitary mass generally needs to be larger than 6 millimeters before it's going to cause hypogonadism. Hyperprolactinemia, of course, prior radiation surgery, infertility. I would say you want to avoid testing in acutely ill patients, since we know that acute illness can suppress testosterone levels. Going through the lab evaluation, so you want to do at least 2, preferably 3 morning fasting samples, testosterone peaks in the morning. A word here about the Providence lab testing. I don't know if you've noticed that the reference range when you order a total testosterone through the Providence lab has changed pretty significantly this past year. Whereas the lower limit of normal used to be 230 or so, and it went down to, I think it was like 80 or 100. And so I've been speaking with Dr. Lutzi, who we're actually fortunate to have here with us today. She's one of the medical directors of the lab. And this past year, they've been working on this issue, and they are now utilizing that study that I had presented earlier on, where they took the 4 large cohort studies, and then they processed all those samples in the CDC reference lab, came up with normalizing equations so they could harmonize the results. And so Providence is using that normalizing equation as well. And so moving forward, I think it's going to be we'll have a little bit more confidence that we're looking at a level and comparing it again, apples to apples, with these studies that I'm talking about in terms of what's normal, what's low normal, what's overtly low. And this is hot off the presses. I just got an email this morning saying that the go live date for this is, I think, today or tomorrow. So moving forward, you're going to see that testosterone reference range change again, but it's going to change back to a range that we're more familiar with. So you want to start with a total testosterone. You can include a free testosterone if you have concerns that their SHBG might be either high or low. So high increases in SHBG occur with aging, and so we're going to see, again, a free testosterone that's relatively lower than the total. Decrease in SHBG is something we see more commonly, obesity, insulin resistance, and so the total testosterone is going to be relatively lower than the free. This happens frequently. We'll get a referral for a patient who has a total testosterone of, say, 260, obese, type 2 diabetes. We check a free testosterone, and the free is actually normal. So it's just a decrease in the binding protein. Now, free testosterone can decrease with obesity as well, but you're going to see a relatively greater decrease in the total. And then if the testosterone is unequivocally low, then you can check an FSH and LH to help figure out if it's primary versus secondary. With primary, this is going to be primary hypogonadism, a testicular issue. FSH, LH are going to be above normal or high normal. They're not the ranges that we're used to seeing with postmenopausal women. So when women go through menopause, their FSH, we know, goes up to 50, 80, 100. Hypogonadal men, we're more often seeing levels in the 20s, 30s, 40s. And then secondary, FSH, LH is either going to be low normal or low. For secondary hypogonadism, you always want to check a prolactin. I've had at least 3 cases of men who present eventually with visual field changes and have these macroprolactinomas. And in hindsight, they'd had a diagnosis of hypogonadism years prior and were on therapy, but hadn't had a prolactin checked. So always want to check a prolactin, always check a ferritin, and always at least consider Cushing. So I certainly don't screen for Cushing's in everybody, but you at least want to think about it when you're looking at the patient and talking with them. And then a pituitary MRI, either if there are other pituitary hormone deficiencies or if they have visual field changes, I'd say refractory headaches, those would be reasons to get a pituitary MRI. And then there are these cutoffs that are thrown about for at which point you should get a pituitary MRI, even if they don't have those symptoms. Generally, think about less than 250 in younger men and perhaps less than 150 in older men as reasons to get a pituitary MRI. So the next question, for testosterone administration, which route carries, I skipped forward to the answer. Which, you guys probably, I'm sure you knew it anyway. Which route carries the most risks? So which is the riskiest way to give testosterone? Topical, injection, orally? Viking River cruise. Someday I'm going to go on a Viking River cruise. I'm going to save up money. So oral. So we recommend against oral therapies. There is some risk of hepatotoxicity. With the injections, the standard dosing is enanthate or cypionate. 200 mg per mil is the concentration. The standard adult male dose is 1 mil every 2 weeks, but for a lot of guys, this will lead to too much in the way of peaks and valleys. So they'll kind of feel like Superman for a few days afterwards, and then they'll feel fine, and then they're kind of drifting down again before the next dose is due. And they're symptomatic with that. If that's the case, then they can go to a half dose once a week, and that evens it out pretty well. The pros, it's less expensive. You get dependable absorption. Dependable is probably a better word than consistent. You're able to titrate pretty finely. Cons, it's somewhat inconvenient and it is painful. It's an IM shot. Topicals are more expensive. Daily administration. With the gels, there is some risk of transference, but that really only occurs if the patient is completely unaware that that's a risk. So if they put on their topical testosterone and then they have intercourse within the next few hours, direct skin-to-skin contact, or there's been case reports of kids, climbing on grandpa's lap. There are instances where the children then can develop hirsutism. So that is a risk, but it's probably talked about more than it actually happens. I think as long as the man is aware of it, they put it on an area that's going to be covered up by clothes, and they're fine. Patches can lead to some skin irritation. There are these other forms which I don't have any personal experience with, a buccal tablet, subcutaneous pellet, nasal spray. I know some of the urologists are using the subcutaneous pellet, and I've heard good things about that. It is an inter-office procedure, and I'm an endocrinologist, I don't do procedures very well. I'm not very good with my hands. So I leave that to the urologist. For monitoring, you want to check a serum testosterone. If you're doing injections, it should be midway between the injections. If you check it right before the next dose is due, when the person's in your office, their level probably will look low. With the gels, you can check the level any time of day, but you have to expect variability. And so the recommendation is that you don't make a dose change until you've checked at least 2 levels, which is somewhat cumbersome, because you can get results anywhere from 200 to 600. It's really all over the place. So when somebody's on a gel, I might check the level, but I'm going a bit more on symptoms and their other outcomes, the hematocrit, and how they're feeling, basically. And if they consistently have levels that are low or consistently high, then that probably does suggest the dose is either too low or high. But I'm generally not using levels in men who are on gels to make a dose change decision that day. For the patch, you want to check it 3 to 12 hours after application. These are, again, the guidelines for monitoring their prostate. Again, that we talked about earlier, the PSA data, I'm not sure how valid that is, but this is what the guidelines state currently. And then you want to check the hematocrit before, soon into therapy, and then yearly, and hold the testosterone if the hematocrit rises to more than 54%. And I think somehow I missed a slide earlier. I'll just say quickly about the hematocrit. So we know with hypogonadism that hypogonadism contributes to anemia, and when the hypogonadism is treated, the hematocrit rises. One of the risks of testosterone therapy, and I'm not sure what happened to the slide, I might have just skipped over it. One of the risks with testosterone therapy is erythrocytosis. So sometimes the hematocrit can get too high, and that is linked with DVTs and stroke risk. And so there is a black box warning from the FDA now surrounding that and testosterone use. When they look at the data, it turns out the men who end up with DVTs or stroke on testosterone either had high hematocrits as a result of the testosterone, or of the men who didn't have high hematocrits, when they studied those men in one paper, 39 out of the 40 of them ended up with some previously undiagnosed thrombophilia. So I think it's helpful when you're starting testosterone to just do a quick question. Have you ever had a blood clot? Has your family member ever had a blood clot? To try to uncover some of those previously undiagnosed thrombophilia. And then again, to hold the testosterone if the hematocrit rises. So thinking about who to treat, I would say a definite yes category is going to be hypogonadism due to known pituitary or testicular pathology in men of any age. All the original studies looking at severe hypogonadism due to pituitary disease included men of all ages. So if I, not uncommonly, will have a man who's in his 60s or 70s who presents with a large pituitary tumor. He's clearly hypogonadal. As long as he doesn't have any clear risk factors and he's symptomatic and he wants to try therapy, I will certainly try testosterone therapy and then just stop it if he doesn't have any clinical response. This big maybe category, of course, is the black box. So this questionable subset of patients who might have this late onset hypogonadism. Consider treating if their levels are definitively low, so less than 200 to 230, depending on age, accompanied by symptoms. You would never treat just the lab number. And then I generally discontinue clinical response if they don't have any clinical response by 6 months. And patients are usually happy with that approach. If they don't have any response, they really don't want to be using an injection. And then, of course, no, you should not treat if their testosterone levels are normal or clearly in the mid-normal range, or even if they're in the low normal range, but consistently there, and they don't have any other findings. So going back to those first two less clear-cut cases, so this 52-year-old man with a BMI of 32, diabetes, low libido, requests testing for low testosterone. Total testosterone is 290. I'm sorry, I think I got the number different than in the first slide. Free testosterone is 47, so that is normal. He probably has sleep apnea. He notes he had stopped exercising and gained some weight in the past few years. So for this gentleman, my recommendation would be a sleep evaluation to look at for sleep apnea, see if there's some other reasons that he's tired. Resume exercise and attempt weight loss. We do have a number of studies showing that if you are successful with weight loss, that the testosterone rises accordingly. And then this gentleman, 68-year-old man who's very healthy, exercises regularly. He's noticed a decline in libido and endurance. He requests testing for testosterone. His total T is 190. Free testosterone is even more significantly low. He's mildly anemic. He's got osteoporosis. So for this guy, if he had no contraindications, I would discuss the risk and benefit and consider testosterone therapy. I think that'd be reasonable to do for him. So a couple of real quick summary points. Testosterone declines with age. Low testosterone is a marker of poor health. Low testosterone appears to be a consequence of poor health, but in some areas there's probably also situations where the very lowest testosterones contribute to poor health, especially we know in those androgen-sensitive tissues like the bone, lean muscle, blood counts, hematocrit. And in general, the way I think about it, the lower the testosterone, the more definitive the underlying diagnosis, the more favorable the benefit-risk profile. So it's hard to give cutoffs. Everybody's on a continuum, of course, but in general, the lower the level, the more symptomatic, the more likely they have an underlying disease, the more likely they are to get benefits. And that is the end of my slides. Thank you very much. We have a couple minutes for questions. Yeah.
So, I didn't hear any kind of convincing or definitive association with prostate cancer.
Right.
Given that's the case, since we don't screen for prostate cancer in men who are not on testosterone, why would we screen for men who are given testosterone too? Because if we know their PSA is going to rise, they're just going to end up
Yeah.
in the rabbit hole of urology and biopsies. So why not make them more the argument to not screen?
I think you could certainly make that argument. I think it's a hangover fear. Oh, sorry. Yeah. So you smartly asked, if we don't screen for prostate cancer in men who aren't on testosterone therapy, why would we do it in men who are on testosterone therapy if the data is pretty convincing that testosterone doesn't increase the risk of prostate cancer? And I think you could make that argument. I mean, I think the last time the Endocrine Society guidelines were updated was 2010, so that's those guidelines. I think a lot of it is hangover fear that we're all taught that prostate cancer is testosterone sensitive, and we use androgen deprivation therapy for prostate cancer. So, of course, if we're giving somebody testosterone, we're all fearful that we're going to increase that risk of cancer. But you're right, the data just doesn't show that. So I think you could make that argument, and you could certainly decide that that's the smart way to practice, and you're probably going to avoid a lot of unnecessary intervention and talk to the patients about that. Yeah.
In the studies, you talk about different things that they control for, et cetera, especially bone density
Yeah.
bone study. How do they deal with exercise and physical activity in the studies? And then can you say a little bit more about, the case examples, the role of physical activity in that middle group that you're not so sure about what to do, even though they have a little bit of stuff.
Yeah, so the question is, how do they account for physical activity in the bone density trials?
Especially weight bearing.
Weight bearing. I don't know that they do. I mean, I think that information is so reliant on the patient's history and hard to quantify. I don't know that they do, but I think that's certainly something that you think about when you're seeing the patient in front of you. I mean, I know I do that if I have somebody who's on the fence of whether or not they need a bisphosphonate, but if it's somebody who's exercising regularly and not falling, that influences your clinical judgment appropriately. So, but I don't know in the study, I don't think they do account for physical activity. And then for the physical activity, you asked about the physical activity in that maybe category. Can you give an example of what you're thinking about?
Besides general,
And do you mean to try to improve testosterone levels naturally, or to?
Yeah.
Yeah.
Are there studies that
Yeah.
support that?
Oh yeah. So weight loss increases testosterone. So I talk to my patients about that a lot. There's been a lot of studies looking at why Americans are overweight. We talk about mindless eating. We talk about food journaling. So really trying to get focused with weight loss, and that should help the testosterone. Exercise can naturally boost testosterone. So resistance training, building muscle on your own can naturally boost testosterone. So we talk about that, and I have had a number of patients who are kind of borderline, and then they get on those issues and they come back and their levels are higher. I don't know how well this has been studied, but I believe improved sleep hygiene can improve testosterone as well. So if you think about any form of chronic stress on the body, physical or emotional, can probably lower testosterone. If you're not sleeping well, or if you have untreated sleep apnea, that's going to be a factor. So if we can improve their sleep hygiene, that's also going to improve their testosterone. Yeah, thanks. Yeah.
Could you speak to then sleep apnea and testosterone, like how you count it, just because that's often a factor, like if people have sleep apnea?
Yeah, so what I understood over the past 5-10 years was that untreated sleep apnea can make testosterone, can cause testosterone to be low, and then if you give those patients testosterone, sometimes that can make the sleep apnea worse. But then there's been other studies more recently that have made me more confused, showing that actually giving testosterone back doesn't worsen sleep apnea. So I'm not sure if giving testosterone worsens sleep apnea or not. I do think probably if the sleep apnea is untreated, then that can make the testosterone lower. So I do try to target that, have them get that treated first. Because a lot of times, of course, if you get your sleep apnea treated, then that's going to also help with your energy, your motivation to exercise, and motivation to stick to a good diet plan, that type of thing. Yeah. Yeah. So the question is there ever a role for the use of SERMs or aromatase inhibitors? That's mainly been studied in the fertility literature, of course, for infertile men. There are a few studies looking at the use of Clomid for men who might have a temporary cause of hypogonadism. So if I've got a guy who had a pituitary adenoma and he underwent surgery to resect that, and we don't know if that axis is going to recover or not, but they're pretty symptomatic. Sometimes I'll start them on Clomid for 6 to 12 months, and often they have a good response, and then we wean them off of it and see if that continues. So I look at Clomid. Clomid appears to be effective in some people who are still able to have a gonadotropin response. The issue is we don't have the long-term studies on it, so I will use it if I think perhaps their hypogonadism is going to be temporary. If I think it's going to be long-term, then I wouldn't put somebody on it long-term. And the same for the aromatase inhibitors. Yeah. Yeah, so the question is with narcotics and dose dependency and duration of treatment and effects on testosterone, there might be those thresholds, but I'm not aware of what they are. I know in general, the longer acting narcotics are more likely to induce hypogonadism. When they, I think any insult, whether or not it's glucocorticoids or anabolic steroid use or narcotics, when you come off of them, it can take a good 1 to 2 years for that axis to recover, and sometimes it never does recover. So if I have a motivated patient who wants to get off narcotics, obviously that's great, but I just try to counsel them to be patient. Potentially that would be a time that you might use Clomid temporarily, see if that can get their levels up, and then take them off of it after a year and see how they do. So that data might be there, but I don't know it in terms of the actual dose or duration. All right, thank you so much. Thank you.